Hello and welcome to Module 6, Assessing Readiness for Change. I'm Dr. Nicholas Pennings, and this is the Nicotine Cessation Training Program. Some of the barriers to change for tobacco users include both physical and psychological withdrawal. The physical withdrawal produces mood changes, irritability, depression, anxiety, poor concentration, insomnia, and hunger. Psychological withdrawal creates cravings, situational urges, triggers associations, and can create a sense of loss. Desire to quit smoking must be strong enough to overcome both the physical and the psychological withdrawal. And very often smokers have an ambivalence towards change, and this is just a natural response that they are going to have likes and dislikes to their smoking, and those likes and dislikes persist even when they initiate the quitting process. One of the ways of assessing readiness for change is the trans-theoretical model for change. And trans-theoretical model for change includes pre-contemplation, contemplation, preparation, action, and maintenance, as well as sometimes includes relapse. Now, the goal here is to move patients along the continuum, move from each stage of change. You want to identify where patients are, what stage of change they're at, and what can you do to move them on to the next stage. In pre-contemplation, the patient's often not aware that change is even needed. The pros do not weigh the cons in their eyes. They are often quick to be defensive or avoid talking about any kind of change or about quitting. They also are quick to justify their behavior. The goal here is to get them started thinking about quitting and letting them know that you're available to help them. People are not going to move from pre-contemplation to action just because of your recommendation. People in contemplation are more aware of their need to change. They recognize the negatives of not quitting, and they're concerned about their behavior. They're thinking about quitting, but they don't necessarily have any specific plans to quit. They may be willing to take some suggestions and be open to some discussion, but not ready to make a change yet. And here the goal is to get them to start thinking about some quitting strategies, what they can do to help to quit. Hopefully then they move on to preparation, and people in preparation really do intend to change. They recognize that the pros of quitting outweigh the cons of quitting, and they have plans to make change, but they haven't made specific goals. They're often more willing and open to suggestions. And people who are in action phase are taking steps to change. They have a specific plan on how they want to quit, or they might need some guidance and support with respect to that. And they may even recently have quit and still be considered in that action phase. People are considered in the maintenance phase once they've been able to quit tobacco for at least 6 months. This is a good time to, one, reinforce their success, but also a good time to introduce reasons why they or what they should do to avoid relapse. Relapse is occasionally included in a trans-theoretical model for change. It's important to recognize the difference between a lapse and a relapse. Somebody who just happens to smoke a cigarette, if they're a smoker, that's not considered a relapse. It's really just considered a lapse, a momentary light up, have one. That's not really a relapse. What a relapse is if they're continuing to use tobacco and get back to their previous levels of use. The key here is for them to learn from their experience, that recognize what made things go wrong, what made them relapse, and then to try again. One of the things that we'll be talking about is motivational interviewing. That'll be in the next lecture. And part of assessing readiness and motivational interviewing is looking at the importance, confidence, and commitment of the person for change. And what we use is the readiness scale, and this is a useful scale where we ask the patient on a scale of 1 to 10, with 10 being the greatest, how important is it for you to quit? And also, how confident are you that you can quit? And on a scale of 1 to 10, with 10 being the greatest, how committed are you to quit? And this gives you a good idea of how ready someone is to make a change. Now, one of the things that we is important is how do you respond to the readiness scale? And most people will come back with an answer that is less than 10. If they come back with 10, that's fantastic. But if it's less than 10, for example, if they say it's a 7, you don't want to ask them, why is it not higher? There's a natural tendency to do that. So you might say, well, what's going to make it a 10, or why is it not a 10? And when you do that, then patients are going to be thinking about all the reasons why they don't want to smoke, because they're thinking about all the reasons why they're not 10. So that tends to elicit what we call sustained talk, and why they want to keep doing what they're doing. Instead, what you want to ask is, why is it not a lower number? Why is it not a 4? What that does is that elicits change talk. They're going to then be saying all the reasons why they want to stop using tobacco. So when they use a readiness scale and they give you a number, pick a lower number, and it tends to elicit a better response. So in summary, quitting tobacco is a gradual process. The trans-theoretical model for change helps to assess the readiness for change and use the readiness scale to measure readiness as a tool to elicit change talk and help them on their way to being smoke-free.